The next class of drug we shall be talking about are thrombolytics. Now let's take a look at the word. Thrombo means clot, lytics means to lyse. So we talk about clot busters. That's right. So we're going to be talking about clot busters. That's what I call them. All right. So we got a nice little ball of clot. We got somebody that to put a sniper in that and break it apart. Now what drugs are thrombolytics? The first one is known as alteplase. Alteplase, also known as tpA. tpA stands for tissue plasminogen activator. And we're going to talk about that in a minute. Another guy in their class is retiplase, RPA. And tenecteplase. TNK, tpA. Now what I want you to notice, every time I tell you about these drugs and you feel like, my goodness, how am I going to remember tenecteplase and retiplase and alteplase? For you, just memorize one. And because I want you to look at their names. They all have T-place, T-place, T-place. So alteplase. The most important of all them is tpA, which is also alteplase. Okay, you're going to see this on the boards, and I guarantee you, you're going to see it on the words because I work in the emergency department and I use it when it's required for patients that have ischemic stroke. All right, so you're just not going to see this drug once. You're going to be seeing it for the rest of your career. All right? So let's talk about how this drug actually works. I said that they're clot busters. Clot busters. Well, how do we bust a clot? We've talked about how we form a clot. Let's figure out how the body does this. Normally, plasminogen, which is an inactive form of plasmin, so tpA, which is the tissue plasminogen activator. Plasminogen is found in the tissues and it needs to be activated. So the enzyme that's going to activate plasminogen into plasmin is a tissue plasminogen activator. It's really not rocket science, guys. Take a look. tpA, that is alteplase. So tpA converts plasminogen to plasmin. Now, what does plasmin do? Well, plasmin actually cleaves off the fibrin mesh. Oh, so we still have a fibrin mesh here. So we're going to use, that's going to be plasmin, chopping off all the hard work that we did to make this clot, busting them open. See that? That's going to be plasmin. Plasmin is going to be chopping off all the fibrin mesh and falling apart, and then the platelets fall apart and the clot is released. Now, this drug also has a direct or indirect effect and also cleaves thrombin. All right? It cleaves thrombin. Thrombin is that factor 2A that I told you about earlier on. And once it cleaves thrombin, we can't have activation of those fibrinogen anymore. Okay? Its effect has an effect on PT and PTT. PT and PTT. But has no effects on platelets, right? Because I told you, it doesn't touch platelets. It's only touching fibrin. And fibrin is coming from fibrinogen that needs factor 2A, and which is thrombin, right? That prothrombin is factor 2. Factor 2A is thrombin, all right? So it has effect on PT and PTT. So they're going to be prolonged because it's affecting the clotting cascade, but has no effects on platelets. All right? Platelets can mind their own business. It's not going to care. All right? So what do we use it for? Well, anytime we clot. When do we clot? Well, patients develop myocardial infarction. So in LEMI, in early myocardial infarction, you can give tpA But usually today in clinical practice, tpA is actually used more for acute ischemic stroke, especially if the stroke is within the first 3 hours, okay? Early ischemic stroke. And the goal is, if this is the brain, all right, and let's say these are the blood vessels that's feeding the brain, and there's a clot here. Let's say you have a middle cerebral artery infarction, and you give a tissue buster. When it opens up the clot, now there's good blood flow to the rest of the penumbra, which is the rest of the brain tissue that's not been infarcted, and you can save the brain tissue because the clot has been busted. But this only has to be given within the first 3 hours. And make sure there's no contraindication to giving this drug. It's also used as a direct thrombolytic for severe pulmonary embolism. Now, what do we mean by severe pulmonary embolism? If a patient has a big saddle embolus and they have a right heart strain and they have no contraindication, you can give them a clot buster to clear up that clot so blood flow can get into the pulmonary vasculature and then can be enough oxygen binding to the red blood cells and getting more blood to the rest of the body. Okay, so basically those are the use of tpA. And remember, just memorize tpA, and because all the other names all have T place in it, that's how you recognize they are thrombolytics. Thrombolytics. All right, so what toxicity is going to be tested? Well, these are all anticoagulants. My blood it's going to bust a clot. That means I can bleed. If it's a clot buster, so if you can see that you really don't have to memorize the first, at least the most common side effect, because they all have the same side effect. They are all anticoagulants. So the first toxicity is it's going to cause bleeding. Okay, bleeding. Now, tpA is contraindicated in any patient that has active bleeding. Really? What color is a brown horse? I believe it's brown. Well, if somebody's bleeding, why would you want to give them something that's going to bust up the clot? Because think about it. If the body is trying to clot while you're bleeding, why would you want to give a clot buster? That's actually common sense. But guess what? You need to memorize that. That is very important. Do not give a patient that has active bleeding tpA. Caution. Tread with caution. All right? Now, also a patient that has a history of intracranial bleeding. If somebody has a history of hemorrhagic stroke, they bled, they busted up a brain aneurysm, you cannot give them tpA. You know why? Because they're going to bleed. Do not give patients that have active bleeding in their brain, a history of it, or even a patient with recent surgery. If a patient has recent surgery, you can't give tpA because they just cut through their skin and their body still try to heal and form clots. If you give them tpA, they're going to bleed. Got it? Also, if a patient has a known bleeding diastasis or severe hypertension. So these are all severe contraindications to using tpA. All right, if the patient has severe hypertension, if the blood pressure is 220 over 120, you cannot give the patient tpA, all right, until you bring down the blood pressure to around 180s, okay? So that is very, very critical. You can't give a patient with severe hypertension, all right, tpA. Also, this is a board question that they're going to test you on drug toxicity, and I'm going to give it away for you so you and I can smile walking away from the exam. So when they test you on overdose or toxicity of tpA, the answer is aminocaproic acid. Aminocaproic acid. All right? So it's an inhibitor of fibrinolysis. So remember this drug, aminocaproic acid. So it took me a while to be able to figure out how to memorize, and I said, Leonardo DiCaprio, sounds like caproic acid. Although in this case we have aminocaproic acid because it's a different medication. You often never hear the word. So I watched Titanic the movie, and I'm sure you saw the Titanic. It's a pretty good movie. The name of the actor, that guy that eventually died at the end of it, oh, sad, right? His name is Leonardo DiCaprio. All right, Leonardo DiCaprio. So I looked at the name and said, oh, Caprio, caproic acid. So that's the only time you will ever hear this drug. So whenever you hear it, think of the Titanic and think of tpA, because Titanic starts with a T and tpA starts with a T. That's how I remember it, okay? So if you remember Titanic, all right, the large ship that sunk in the middle of the sea, and Leonardo DiCaprio, that is how we're going to reverse it. So hopefully when the ship will start to sink, we can kind of reverse it back with, if Leonardo could do that, that would have been really, really super cool. But he didn't, according to the director. All right, so that brings us to the end of thrombolytics.